Hello everyone, and a warm welcome to today's LongITools Policy Forum, an exposome approach to understanding cardiovascular disease across the life course. I'm Joan Boulding from Beta Technology in the UK, and Beta is a partner in the LongITools project. I'll be your host for the session. LongITools is one of 9 collaborative research projects funded by the European Research Programme Horizon 2020 to study the human exposome. Our role is to ensure that the LongITools research findings are understandable and accessible to all of our stakeholders, and where possible are used to help inform policy-making decisions. Throughout the projects, these policy forum meetings will bring together stakeholders around a specific topic or challenge. The aim is not only to raise awareness of our activities, but also to gather stakeholder input, to get to know one another and to share with one another our knowledge and best practice. I'm delighted to see that today, which is also World Heart Day, we are joined by a range of stakeholders with representatives from academia, intermediary organisations and public bodies. Thank you for taking the time to join with us. Before I get started, I'd just like to run through some housekeeping though. As you will have noticed from the notice that's being shown on the screen, for our future reference, the event is being recorded and transcribed, and the recording will be publicly available after the event. Could I please ask that all participants remain muted unless you're invited to speak? And please do leave your cameras on if possible, especially when you are speaking. You will be able to ask our speakers questions after all of the presentations that we have this morning are finished. We'll then open up the floor for a more general discussion. If you'd like to ask a question and you want to make sure you remember it, please use the chat function or use the raise hand emoji, which is at the top bar of the screen. And by all means, please use the chat function to put any comments or observations you may have. If you'd like to like any questions that you wish to see answered, we can use that to prioritise questions if we become limited on time. The aim is that this is an interactive event and an informal networking event, so please do use this session to raise any questions, share your experiences and knowledge, and do introduce yourself to your fellow delegates. So we've got quite a few people to talk today, and I'm very pleased to welcome all of this morning's speakers. They include speakers from the LongITools project and other organisations, and each of them bring different knowledge and insight into cardiovascular disease. So firstly, we have Birgit Berger, the CEO of European Heart Network. Hopefully I pronounced it right. Over to you, Birgit.
Thank you very much, John, and welcome everybody. As John already mentioned, it's the World Heart Day, and I'm delighted to start the day like this. That's excellent, and to contribute to improvement cardiovascular health, which is my job. I'm the CEO of the European Heart Network, and we are actually a network of I take control. A network of foundations and associations dedicated to fighting heart disease and stroke, representing patient interests and funding research throughout Europe. So CVD research is quite important for us as well. So our mission is to take a leading role in the prevention and reduction of cardiovascular diseases. I think it's the topic also of today a bit, the risk factors, in particular heart disease and stroke, through we work policy, advocacy, networking, capacity building, representing patient interests and research so that they are no longer a major cause of premature death and disability throughout Europe. Our vision is that every European has a right to live a life free from avoidable cardiovascular disease. So we see a little bit what has happened in the past 2-3 years, that health has become an important factor, that there are 10 crises, climate crisis, but also conflicts, war, etc. And we've seen that in a crisis, people already suffering from non-communicable diseases like cardiovascular disease are touched very, very hard by it. So we see that we need to move on in CVD because we have another wave coming, because the morbidity, it's killer #1 in Europe and worldwide, CVD. We have 60 million people living with CVD in the EU, 13 million new cases of CVD every year, 1.8 million deaths per year in the EU. And so there are 24 premature deaths in men and 70 premature deaths in women. I think it is said that the numbers are getting more and more equal. In a way, unfortunately, that the numbers going up and at the same time spreading equally. So this is not a good sign when it has been maybe lower in a certain group. Also, social economic determinants play a big role, because if you are in a lower income country, you will suffer more likely from CVD than living in a higher income country from Western Europe. The overall burden of for the economy is 210 billion euros per year, and as mentioned, inequalities in mortality from CVD account for almost half of the excess mortality in lower social economic groups in most European countries. So this is really why we need to change the landscape and need to work. So what are the good news is that I think there's an awareness of policymakers that we have come that far and that it is time to act now. So the WHO Europe has recognized that all those heart attacks and strokes are major killers in all parts of the world. 80% of premature deaths from these causes could be avoided by controlling the main risk factors. And I think that is a bit the topic we are working on today. So the main risk factors really are tobacco, unhealthy diet, and physical inactivity. With these three elements, you can already change quite a bit, not only in CVD, but non-communicable diseases overall, but in particular in CVD. We have other risk factors. If you have a high blood pressure, hypertension, as to say, this is another a dangerous element to watch out for. And it should be measured every time you see a doctor, definitely in the primary care. It is so important. Air pollution, I think this is a topic which we'll be discussing more today, is becoming more and more into the focus of policymakers, how much cardiovascular disease also are impacted by bad air quality, not only outdoor, but also indoor quality. So there is certainly an element to work on. And last but not least, though 80% of the premature deaths could be prevented, but there are some diseases and CVD you can't really prevent because you have a genetic predisposition. There's one example, familial hypercholesterolemia. So children are born with a high blood cholesterol level, and this leads to early heart attacks and early deaths just because of that condition. So preventable, it is the good news. We can do something about it, and we should actually do it. While looking at a bit at the risk factors, which I was asked to do, we did a survey as EHN in cooperation with the World Heart Federation to develop so-called scorecards. We just give a snapshot. We do a lot of research behind it. So I have a very bright young colleague, Isabella Sina, who has done studies on 5 countries, Germany, France, Spain, Italy, and the UK, and put a bit together how these countries are doing on the one side on the epidemiological factors, but also what is happening at policy level. So you have the advantage to have a bit of a snapshot here also on other topics, but I would focus on the risk factors. So for Germany, you will see that the unhealthy diet, tobacco use, and low physical activity in adolescents are important public health issues in Germany. Ischemic heart disease and stroke continue to be leading causes of death in Germany. And what is interesting, that German adults are more physically active than most EU countries, but adolescents have low physical activity levels. And I think we are talking a bit too electronic devices, a bit too maybe also COVID circumstances where young people were forced to isolate at home and were not allowed to go out a lot. But I think it's a trend we have to look out for when we are planning how to make our cities more physical activity friendly, so we can walk to school, to the work, etc. How we enable physical activity among all parts of the population. We also see smoking rates have decreased because we have a good, a better tobacco control policy than in the past. So they have decreased in Germany among adults and adolescents over the past decades, but they're still higher than in some EU countries that have achieved further progress. So this is a bit the picture of Germany. I'm turning to France. There we also tobacco use. It is really a big risk factor, tobacco use. Alcohol misuse and physical inactivity in adolescents are the factors in France. Whereas France has typically performed better compared to other EU countries in risk factors in overweight and obesity and hypertension. But there are some worrying signs, such as an increasing rates of adult obesity and rates of tobacco use in youth and adults remaining high. So this is interesting to watch out for France. Maybe one aspect I found very interesting, that in France it's the lowest current health expenditure covered by household out-of-pocket payments. So that's I think is interesting. Moving over to Spain, again, it's adult tobacco abuse and physical inactivity and poor diets in adolescents that are important public health issues in Spain. If we look maybe as a remark, what you can do as policy aspects, for example, there are taxes on unhealthy food, sugar-sweetened beverages, but in Spain it is only. Oh, I'm not. Oh, sorry. Thank you for the comment. I have not moved on my slide, so I'm doing quickly. Going quickly to France. Here's the France slide. And now I take you to Spain. Thank you for the remark. So in Spain, as mentioned, there are taxes on unhealthy food, sugar-sweet beverages, but they are only implemented as a federal country in Catalonia. So there's still work to do, but it's a good trend. And what Spain is currently very famous for, from a policy perspective, they have a national strategy addressing CVD and its risk factors. So it's brand new. It was published this spring in May, it's the only, let's say, national plan which exists currently. It's active, so we hope that we inspire other national CVD plans across Europe. Looking at Italy, again, we are staying with the risk factors: tobacco use, physical inactivity. But there's also an overweight obesity issue in adolescents, which is becoming a very prominent, in particular in areas of lower socioeconomic status, maybe parts to poorer diets and lower physical activity levels in that part of society. So though Mediterranean diet, the obesity is increasing in Italy, but I think it's a trend all over the world, unfortunately. Then last but not least, we are going to the UK. Again, adult obesity, alcohol consumption is prominent, and adolescent physical inactivity also trending much. What is positively to report is definitely the famous taxes on sugar. Here, I think the UK is a bit of a leader, and that they introduced taxes for sugar-sweetened beverages, and they also have quite a strong policy, I think, on legislation in banning smoking in indoor public places. So that is a bit the tour. I want to take you through our latest study there with the scorecards, and I hope we can continue a bit more, and also going more to Eastern Europe. But it's actually quite interesting. What I've mentioned before, what exists in Spain, we would love to see that overall in Europe, but also at European level. I hope you see now the slide, what we would like to see as a plan. So we in EHN have mainly 3 pillars, and whenever we discuss strategy, this pillars remain the same throughout the years, funnily. So we focus much on prevention, and that again brings us to the risk factors. So where we see it is not it's not just a lifestyle disease. What we would like to see is that the individuals have a healthier environment. So it is not the responsible of the individual only, but it should each person should have access and, let's say, a choice for a healthier lifestyle. And that means access to healthier diets, maybe not just by labeling, but also by reformulation of food, so that food manufacturers are forced to have less fat, less sugar, less salt in the way they compost food. Marketing ban of unhealthy foods, smoke-free generation is a big topic, and promote active living, clean air. So this would be our wish list. And I think a lot of CVD, as mentioned, 80% are preventable. What could we reach if we already had healthier living environment? Then the other strong leg, I think, is besides primary prevention is secondary prevention. So that means catching individuals early at high risk, and also having once it has a CVD event has taken place, we have good re-evaluation policies and enable that throughout our society. Then we look at patient care. We would like to see modernized cardiovascular patient pathways by supporting interdisciplinary healthcare models. So what we're doing today, bringing different professions together, researchers, policymakers, and let's say a civil society, is a mean of creating a dialogue and a discussion. But this should also happen, let's say, in a healthcare system, that we have the primary care, secondary and tertiary care are all being streamlined, and that they maybe where are the gaps are that digital health could help to strengthen our patient care. And in order to make this happen, there's this current legislative dossier ongoing of the European Health Data Space. So we hope that member states invest in decreasing digital and health literacy, because you need to have the structures, but you also need to have people to know how to navigate it from a patient's point of view. And last but not least, research. So we would love to see advanced knowledge and innovation by funding innovative research, and also with the aim to improve patient outcomes and the quality of life for people living with this CVD. But as I mentioned, all areas, whether it's patient care, whether it's research, it's prevention, is much helped by digitalization. I was yesterday speaking about the transformation through digital tools, how much it can be done in the primary use of data, let's say, for the patient in the healthcare system, but also secondary use of data for innovation, research, etc. So I think I come to the end of my presentation. I hope I've kept in the time which was allocated, and I'm happy to take any questions. Thank you so much for your attention.
Thank you, Birgit. Yes, we'll have questions at the end if that's okay, so we can keep going. And I say, if you want to put them in the chat, please do. So yes, thanks very much for that. I would like to introduce a few speakers from LongITools now, starting with our LongITools project coordinator, Sylvain Siebert, and he's a professor of life course epidemiology at the University of Oulu. So over to you, Sylvain, if you'd like to take control.
Hey, thanks a lot, Joe, and thanks a lot, Birgit, for this really important introduction. I hope you can hear me well. And so, yes, I'll make a very short introduction about our project, the LongITools project, and also the HEN project, the European Human Exposome Network. So let me check whether so to start with, this project, which is called LongITools, takes place into a larger network of European research project called the European Human Exposome Network, where one solid goal is to understand the health impact of environmental exposure, and how can we understand the role of environmental factors in the risk of chronic and non-communicable diseases. So it's a network that joined 126 research groups in 24 countries, 9 very large research projects that receive quite a substantial amount of fundings from the European conditions to try to, as Birgit was mentioning, to try to understand all those preventable factors related to environmental factors, social factors are working and are affecting the risk of cardiovascular diseases and heart diseases. So in the LongITools project, which is part of this network, we are especially interested in to understand how this relationship between those risk factors from the environmental factors, so air pollution, noise pollution, the built environment of urban factors, relates to the psychosocial factors. So as Birgit was mentioning, how does those risk factor relates to lifestyle, to smoking, to physical activity, to diet, and how these things develop through the life course, so from early age onwards, and how does it work with predispositions to develop trajectories for healthy or unhealthy life with together linking to cardiovascular diseases. And through this process, so we really trying to understand how health inequality develops and how does it develops in sort of vulnerable population and groups, and we are developing it in European projects to also understand those country-specific factors that Birgit was also mentioning. And we are in this project, so this is a research project where indeed we are trying to enable better research and also trying to find solutions and enabling innovation in the process. We are using an exposome approach where we're trying to understand how the biological response and the risk factors are set by a series of in a complex systems where many environmental factors, as you can see in the outside circle, might act through the life course to modify the biological response and the risk for diseases. But this is the LongITools project as a whole, and here we have I'm very happy to introduce 2 of the research projects that are developed as part of this project. One on cardiovascular health of children aged 5 years old, and then by Dr. Rachel Climey, and then another project by Dr. Ana Goncalves Suarez, who is going to present her work on prenatal urban environment and blood pressure trajectories from childhood to early adulthood. So and now it's my great pleasure to introduce Dr. Rachel Climey, who is presenting from Down and Under at the University of Tasmania in Australia, where she also holds an honorary position at one of our LongITools partners in INSERM in Paris. So Rachel is Australian National Health Medical Research Council emerging leader from the Health Foundation, and she's a clinical exercise physiologist, and her research focuses on the determinants and consequences of vascular aging commencing in early life. So I will, without further ado, it's my great pleasure to introduce you and leave the floor for you, Rachel. So I'll stop sharing, and I think you can take control.
Yes, thank you, Sylvain.
Just hold on a second, please. Let me just get us back to where we need to be.
Sorry about that.
Okay, just take control, please, Rachel. Yeah.
Yes, oh, sorry, hang on. Everything's happening now. I've lost the light in my office too. 2 seconds.
You're not moved
there we go.
enough.
Nope. Okay, take control.
Super, thank you.
Yes. Okay, thank you. Just get myself organised here. Okay. Thank you very much, Sylvain, for that introduction. And yeah, it's a great pleasure to be joining you all today. So as Sylvain mentioned, I'm a research fellow at the University of Tasmania, and I also conducted a postdoc in Paris with a group, an INSERM group there. And the work that I'm going to present now is some work that I've done in collaboration with my colleagues from Paris, and they're part of the LongITools project. So all right. Okay, so as you may be aware, a study published earlier this year in the New England Journal of Medicine showed for the very first time that cardiovascular risk factors in children are associated with an increased risk of both fatal and non-fatal cardiovascular events, such as heart attack and stroke. And this study was conducted in approximately 40,000 people, and the researchers showed that risk factors such as body mass index, blood pressure and smoking in childhood were associated with cardiovascular events in adulthood, and that the risk factors were greater if children had multiple risk factors. So this is really significant, as Birgit mentioned, because the prevalence of these cardiovascular risk factors in children is increasing worldwide. So for example, 57% of today's children are expected to be obese by the time they're 35 years of age. And there's been a 75% increase in prevalence of high blood pressure in children and adolescents between 2000 and 2015. And youth onset type 2 diabetes, which is typically a disease that occurs in adulthood, is now more and more prevalent in young people. And there's 5,000 new cases each year in the US alone. So without effective intervention, there's going to be a substantial health and economic burden associated with cardiovascular disease as our young people age. So as such, primordial prevention, which is the prevention of risk factor onset, is increasingly recognised as a strategy for the prevention of cardiovascular disease. And in line with this, the American Heart Association now advocates for primordial prevention of cardiovascular disease, and they developed a 7-item tool to monitor and promote ideal cardiovascular health. Importantly, interventions in early life, when biology and behaviour are most amenable to change, are more likely to show positive health outcomes. However, the prevalence and determinants of ideal cardiovascular health, as defined by the American Heart Association, in young people is not known. So for this study, we examined the distribution and parental and early life determinants of ideal cardiovascular health in children up to the age of 5 years. We also explored the potential association between cardiovascular health and the cognitive development of the children at age 5. So this study was conducted using data from the Eden study, which is a French cohort study involving mothers and children. The women were recruited before 24 weeks of gestation in France between 2003 and 2006. The study involved repeated in-person clinical examinations of both the mother and the child, along with questionnaires relating to parental and child and health lifestyle. We examined the markers of cardiovascular health as outlined by the American Heart Association and shown on the screen now, and defined these as per international guidelines. So these 7 items that the American Heart Association's outlined include physical activity, diet, body mass index, glucose, blood pressure, cholesterol, and smoking. But as the children were so young in this study, we looked at smoking as in a sensitivity analysis because we didn't expect young children to be smoking, so it was more exposure to smoking. And the French version of a validated scale of intelligence was administered to the children at 5 years of age by a trained psychologist. So what did we find? Well, we had complete data for all of these metrics in 566 mothers and children. We found that only 35% of children had ideal cardiovascular health metrics at age 5. So this is at least 5 of those cardiovascular health metrics at the ideal level. And only 39% of boys and only 29% of girls. Boys were more likely than girls to have ideal BMI, physical activity and total cholesterol, whereas girls were more likely to have ideal levels of consumption of sugar-sweetened beverages. The children with ideal cardiovascular health were more likely to have a mother who had ideal diet in terms of fish consumption and fruit and vegetable consumption prior to pregnancy. But there were no other differences in maternal factors between the children who had ideal versus non-ideal cardiovascular health at age 5. Children with ideal behavioural cardiovascular health, so these are the factors that really relate to behaviour, physical activity, diet and BMI. If they had ideal levels of this at age 3, then they were more likely to have ideal cardiovascular health at age 5. And also children who spent less than 30 minutes per day watching television at age 3 were more likely to have ideal cardiovascular health at age 5. So this then, I guess, suggests that these risk factors or this poor behaviour that may commence very early on in life does track to later in childhood, and then we know that that then tracks into adulthood as well. Ideal cardiovascular health was also associated with better IQ of the children. And we only saw a small number of points difference between ideal versus non-ideal cardiovascular health in terms of IQ, but it was the same level that we see between children who are breastfed compared to those who are not breastfed. So it is quite a significant finding. In terms of next steps, we're currently working on some data within the LongITools project and hoping to examine cardiovascular health across the life course from children into adulthood. We're hoping to be able to explore differences across European regions in cardiovascular health and how this changes in the different populations and age groups, and explore how cardiovascular health is impacted by socioeconomic position, environmental factors, and other factors as well. And it is hoped that through this work that we'll be able to help to inform interventions to improve cardiovascular health and minimise the burden of cardiovascular disease in future. So in terms of the take-home messages from this project, only 1/3 of children aged 5 have ideal cardiovascular health. Adverse but modifiable determinants are already evident at age 3 and are associated with cardiovascular health at age 5. Poor cardiovascular health is associated with worse IQ at age 5. And so this then means that targeting adverse behaviours early on in life, such as poor diet and inactivity, should be a priority if we want to prevent the ensuing tsunami of health and economic burden associated with cardiovascular disease worldwide as today's young people age. So thank you very much, and I'll hand over to Anna now.
You need to unmute yourself, please, Anna. Sorry.
Oh, sorry. Thank you. Thank you very much, Rachel. So I'm going to talk about another project we have in LongITools, which is exploring prenatal urban environment and blood pressure trajectories from childhood to early adulthood. So I'm a research fellow in epidemiology at the University of Bristol, and I work as part of the LongITools and one of the work packages exploring the influence of environmental exposures in adolescence and early adulthood. But in the consortium, we work in a collaborative way. So we work with the other work packages as well, exploring these associations across the life course. So the motivations for doing this project. We know that blood pressure is one of the most important modifiable risk factors for cardiovascular disease, and cardiovascular disease is one of the leading causes of death worldwide. And blood pressure tracks from childhood to adulthood. So that means that those children that already have a higher blood pressure during childhood are also more likely to have high blood pressure in adulthood. And there are studies showing that prenatal urban environment, so the urban environment during pregnancy, has been associated with higher blood pressure in childhood. And most of these studies usually assess blood pressure in a single time point. So it's important to know whether this track over the life course. So we wanted to know whether this urban environment during pregnancy is also associated with trajectories of blood pressure during childhood, adolescence, and early adulthood. So for that, we use data from the Children of the 90s, the AUSPAC study, which is a pregnancy-based cohort in the United Kingdom. So we use data from these cohorts as the main analysis. And then for that, we use up to 7,000 children. And this data is spanning from 3 to 25 years old. So we assessed 46 environmental factors during pregnancy, and those involving different domains, including air pollution, traffic-related measurements, food environment, meteorological factors, built environment, noise, and natural spaces. And we assessed whether those factors during pregnancy were associated with trajectories of systolic and diastolic blood pressure from childhood, so around the age of 3, up to early adulthood, around 25 years old. And also, we try to replicate those findings found in AUSPAC in other 4 independent European cohorts. So those were EDEN in France, Generation R in the Netherlands, PANIC, and NFBC in Finland. So what we found in our study. So in the main analysis using AUSPAC, we found that air pollution and some measurements of meteorological measurements, especially humidity and temperature, were associated with systolic and especially diastolic blood pressure. So here to bring an example, humidity was associated with lower systolic and diastolic blood pressure early in childhood, so around 3 years old, and it was also associated with a higher increase in systolic and diastolic blood pressure in childhood. And also for diastolic blood pressure, humidity was associated with a slower increase in diastolic blood pressure during adolescence. When we took those findings forward to the other cohorts, then the associations we found for air pollution didn't replicate in the other studies. However, humidity and temperature did. So humidity, as I mentioned, and as we found in AUSPAC, was associated with lower blood pressure in childhood, but associated with a faster increase in this blood pressure during childhood and adolescence. And temperature, we found the opposite direction. So temperature was associated with a higher blood pressure early in childhood, so around 3 years old, and associated with a lower change in blood pressure during childhood and adolescence. So some of the take-home messages from this project is that we use a systematic approach to assess different measures of this urban environment. So rather than focusing just in a single group of exposures, such as air pollution and the built environment, we looked at the like a holistic approach of this exposome, looking at different factors at the same time. And then we found that ambient temperature and humidity during pregnancy are potentially important not just for specific levels of blood pressure in childhood, but also trajectories of blood pressure, especially during childhood. And even though the mechanisms of the current exposure to temperature and humidity and the impact on blood pressure are better understood, we still need to understand a bit more how these factors during pregnancy can impact later on blood pressure in the offspring. So thank you very much for your attention. And if you want to know more information about the LongITools and this project, then please get in touch. Thank you.
Thank you very much, Anna. Thank you to all of my LongITools colleagues for sharing your research and your results. I would now want to move on to Jeroen de Bont, a doctor from the Karolinska Institute, and Jeroen works on another one of the EHEN projects. So I'll let him explain in more detail. Thanks, Jeroen.
Okay, thank you. Thank you all for attending this session today. So thank you for the introduction, and I will talk a bit about the human exposome and cardiovascular health within the EXPANS project, which is EXPANS is the same for exposome powered tools for healthy living in urban settings. It's one of that Sylvain already commented. It's one of the projects funded within the EN consortium. It includes more than 20 partners across Europe, and it's funded for 12 million euros, and it is a study that will be conducted between 2020 and 2025. So what will EXPANS address? So EXPANS will address one of the most pertinent questions for urban planners, policymakers, and European citizens. So how to maximize one's health in a modern urban environment. And what do we define? We already heard some talks about the urban exposome, and within EXPANS we define the urban exposome as a complex mixture of social and environmental factors of the human environment that individually and collectively have an impact on health. So one of the aims within the EXPANS project is to study the impact of the human exposome on cardiometabolic and pulmonary diseases, and evaluating the impact of intervening on specific factors in the human exposome on reducing the burden of cardiometabolic and pulmonary diseases. So how we do it will answer three major questions. So one of the question is, what aspects of the human environment contribute most to cardiometabolic and pulmonary disease risk, and how these factors interact? We also evaluate if we can use biological markers of complex exposure and of biological effects to get a better understanding of the causal pathway between the exposure and the outcome. And further, we want to know if which intervention strategies reduce exposure to the most damaging aspects, and which intervention strategy most effectively promote health. So how do we do this? So EXPANS will bring together mega administrative cohorts that comprise data from more than 55 million European citizens, and it also will include large individual adult cohorts and matured birth cohorts across whole Europe. So the combination of this administrative adult and administrative cohorts cover the whole lifespans from both an exposome and health perspective, similar as the LongITools project. Finally, we are developing now, we are actually starting this month. It's called the Urban Labs, which include around 5,000 Europeans in 5 large cities. And there we really will evaluate with new apps and GPS and many other tools to really understand how the individuals move and their time activity patterns, how their social network, how is their surrounding of the built environment, and how they interact with the human environment, that we in a future stage can use these tools to use for policymakers and citizens. That is one of the next parts of the project, which is called, that the other goal is to create a long-term sustainable toolbox and infrastructure that can be used to generate knowledge on the urban exposome and translation of this knowledge into actionable information for citizen, public sector policymakers, and private sector companies. So nowadays we have created this toolbox that we will apply to the urban labs, and in a future state this will be accessible within called the Exposome Hub. The idea is to create an open science co-creation portal where scientists, policymakers, and private sector users can upload, access, and share exposome data, methods, and tools while collaborating in virtual workspaces on joint research and development projects. So this is a bit what we will create at the end of the project. It's not still yet available, but in the future you can access this and to provide also tools for the general public, but also for policymakers. And the ideal goal is to identify those risk factors that create a decline in our development at early stage and later stage, and to improve our urban environment to, at the end, create a normal development and decline as we expected. So what are we doing now that I'm working a bit on the project is to answer the first question. So what aspects in the urban environment contribute most to cardiovascular diseases and how these factors interact? So we are currently in really preliminary results, so don't think this is the final results, please. So we are combining data from this administrative cohort, like large data sets from Italy and Greece, which include more than 8 million people. And then we have more adult cohorts, which are followed up since the 1990s. And there we have more individual data that we cannot get from the administrative cohorts that include data from Sweden and Germany. And what we did, we followed those all the citizens until they develop a stroke or they are healthy at the end of the study. And then you combine what are the effects of the urban environment on stroke incidence. So what we did is like, you can evaluate what we have seen, the individual factors, but we want to see if there's a combination of exposures that we are exposed at the same time have an effect of stroke incidence. So what we did is we combined all the factors of ambient air pollution within one, it's called a PCA, that we combine those exposures. So we combine NO2, PM2.5, carbon, and ozone, and we evaluate if they have an effect on stroke. We did the same for the built environment, including green, blue spaces, and impervious surface, which are gray spaces within a human area. And we also want to evaluate if there are some temperature meteorological effect of long-term effects on temperature on cardiovascular outcomes. What we see, I won't go through it, but in a way, what we can see is like a combination of high levels of NO2, PM2.5, and black carbon seems to have some effect in some of the cities, but they are not really statistically significant. And we still want to understand what are really this exposure saying. On another side, we also find that the combination of high levels of green spaces and lack of gray spaces is protective for the effect of stroke. So it's we have less cases of stroke. This we see in Stockholm, Rome, and Greece, and in Augsburg we see some different effects. So it's also seen that within each country we can observe different things, as we also saw in the previous study in Alsbach and in Netherlands. We also find that some effects of living farther away from blue areas, which are water, river, lakes, could be hazardous against the stroke incidence. These are all preliminary results. We don't yet understand that, but we are continue working on this within the EXPANS project. So to summarize some key features of the EXPANS. So in some preliminary analysis, we found a suggestive protective effect of the built environment, capturing high levels of green spaces and low gray spaces. And some others parts of the EXPANS that we will have personalized urban exposome and health assessment over the life course for more than 55 European citizens across 12 countries. Some other aspects that I did not mention is this internal exposome that we will evaluate, such as methylation, transcriptomics, to evaluate this causality. This is not within my expertise. This is another work package, but this in the end of the study, the end of the project, we will evaluate. Approaches to identify the life course impact of the urban exposome on population clustering, their biological consequences, and cardiometabolic pulmonary health. and it has a large-scale tracking on network experiments in the urban labs. So this is a quite a small overview of the big project and some of the preliminary results that we're getting within the expansive projects. So thank you for your time.
Thank you very, very much, Jeroen. That was lovely. I'd like to introduce our last speaker for today. It is Dr. David Warriner, who is a consultant cardiologist at Doncaster and Bassetlaw Teaching Hospitals. So over to you, David. Thank you.
Thank you. Thanks for the introduction. So I'm here to talk to you today about cardiovascular health in Doncaster and how it relates to the previous talks really in terms of the exposome. I have no conflicts of interest to declare. So I must admit, I've never actually come across the term exposome before I got asked to give this talk, so I had to do a bit of Googling. And it appears to me the totality of human environmental exposure from conception onwards, which to my simplistic clinical head says everything but the genes. In terms of what it means to cardiovascular health and exposome, the WHO in 1986 had a very good definition, which has been used repeatedly throughout the last 40 years, really. But rather than being the absence of disease or infirmity, it means a state of complete physical, mental, and social well-being. And to have those three things, of course, you need the exposome. And the exposome is comprised of socioeconomic factors, lifestyle factors, environmental, biological, and psychosocial factors. We'll consider those all in turn for the patients and population in Doncaster and see how they fare. So I work in Doncaster, I also work in Leeds, and data from 2016 from Doncaster shows that Doncaster is one of the most deprived areas in the UK and the second most deprived in South Yorkshire. And some of the areas within Doncaster themselves are among the most deprived nationally in the 10% bracket in terms of employment, education, health, income and crime. So you can see here already the patients and public in Doncaster from a socioeconomic point of view are struggling. How about lifestyle factors? Well, if you come to Doncaster by train, as I do every day, you walk through the train station and usually go through the shopping centre, which is Frenchgate, to get out to the city centre and beyond. And it starts off quite nicely. There's the big mural on the wall, which you can see here. Then you got the escalator, and unfortunately, things escalate quite quickly in terms of just a very high density of fast food outlets. So McDonald's, Costa, Burger King. So very high calorific content, very poor nutritional content. And that's just one example, really. And of course, it isn't the be-all and end-all of obesity and cardiovascular risk, but it gives you an example of the density of outlets, really. What about other things in terms of lifestyle factors? I'll just make my slides bigger, sorry. Here we can see the CCG data from 2017. CCG is an area looked after by GPs in the UK, which has changed recently to ICS. But essentially, it shows here that Doncaster prevalence of smoking is very high. So it's the highest in the demographically similar CCGs, so deprived CCGs essentially. And the UK, I think on average is around 16%, but here in Doncaster it's 22%. So nearly a quarter of all people in Doncaster who are registered with a GP smoke, which is pretty scary, if I'm honest with you. Okay, so that's the first two things covered. How about environment? Do things get any better for the built environment? In terms of environmental factors, the majority of patients and public in Doncaster are obese or overweight, so nearly 3/4 are obese or overweight. And that compares to London, which is only 23%, which is pretty dramatically different, or more nationally, around 61%. So patients and public in Doncaster are big, unfortunately. But if you walk or cycle through Doncaster, as I do, you can see why. The roads are very busy, very dangerous. There's dual carriageways throughout Doncaster. There's not much infrastructure. There is some, of course, for cycling, but there isn't much. And it's pretty scary. So I don't blame people particularly for not choosing to cycle or walk. What about biological factors? It doesn't get any better. You're getting a theme here, unfortunately. So in terms of Doncaster and Bassetlaw, they're part of the same hospital trust. And here we can see in Yorkshire, which is an area in the north of England, they're the two highest prevalence of CKD, so chronic kidney disease. So Doncaster and Bassetlaw, which is pretty much the same area where I work, have the highest prevalence of CKD. And that goes the same for diabetes. And diabetes and CKD, of course, increase your risk of cardiovascular disease dramatically. Psychosocial, so let's consider psychosocial things finally. I mean, in particular, Doncaster has quite a lot of prisons around the area. There's 4 prisons, I think, around 3,500 inmates. They have very complex healthcare needs. And And interestingly, if you compare their risk to the community they derive from, it's very similar, but actually the patients are 10 years younger. So rather than having a heart attack in your 40s or 50s, it's your 20s or 30s, which is pretty dramatic in terms of your life expectancy after that. In terms of mental health and substance disorders, much higher than the general population, so 5 times higher. But very interestingly, despite all these risk factors and prevalence of disease, they're very much less likely to be admitted to hospital. So 24% of fewer patients are admitted, and nearly 2/5 of patients are not even brought to their outpatient appointments. So they're failing to be brought to their appointments, which is damaging to their long-term health, I think. So you can see here, unfortunately, in South Yorkshire and Doncaster and Bassetlaw, we have a toxic milieu of the exposome. So poor socioeconomic factors, poor lifestyle, poor environmental, poor biological, and poor psychosocial. And what does that mean for me as a clinician when I see patients in Doncaster? Well, the end result of any cardiovascular disease process, as I'm sure we're aware, is heart failure. When the heart doesn't pump properly, so be that valvular heart disorders, ischemic heart disease, arrhythmogenic heart disease, etc., the heart stops pumping. And if that's diagnosed, you have a mortality at 5 years of 50%, which is worse than many cancers like prostate cancer or breast cancer. This is bad news. And you can see here, again, from CCG data in Doncaster, it's among the highest in the UK, which is perhaps not surprising when we consider the risk factors we're exposed to. And I guess as a clinician, I can treat disease, or I can try and ameliorate risk factors like smoking prevention, but I can't treat living conditions. I can't treat economic and social structures, other than, I guess, at the voting station. I don't have influence in these things, unfortunately. And in terms of what I see in particular, patients in Doncaster present prematurely and present late, which sounds a bit counterintuitive. However, so patients present prematurely, so rather in the 50s and 60s or in the 30s and 40s. So disease process is very much accelerated, but they present late. So rather than presenting within a few hours or even minutes of onset of symptoms, they present days, weeks, or even months after onset of symptoms. So at that stage, it's actually too late often to get the best outcomes for their disease process. So it's a real bad combination of things to present prematurely and yet late. For example, I'm looking after a patient currently who's a prisoner. He had cardiac bypass a few years ago, which of course is a treatment for usually 3 heart vessel blockages. He's already got impaired cardiac function. He's got heart failure. He's got diabetes, which is poorly controlled, which of course will have led to the other 2 things above as well. He's had heart attacks despite this and lots of stents put in. There's nothing left to stent. His kidney disease is pretty bad. He's nearing the end stage. He's nearing dialysis as well. And he's not for cardiac transplant. So this is the end stage for him. And he's 20, in his 20s, which is pretty scary, even for me as a clinician, to see patients who are so young with very much little left to offer, really. So in conclusion, for Doncaster, there's a toxic milieu of risk factors for cardiovascular disease, and unworried unwell is the norm. Worried well is not something we see in Doncaster particularly. Patients present late and prematurely, and they have poorer outcomes in my experience. And whilst the NHS can treat heart disease and its sequelae, we can't treat poverty, unemployment, or homelessness. But that's what derives and drives these diseases, unfortunately. So I guess my question to the panel and others is, how do we aggressively target risk and those at risk? In conclusion, I would argue possibly it's not the books that made us, but possibly the city we live in that makes us. Thank you.
Thank you, David, and thank you very much to all of our speakers. There is an awful lot of information and knowledge shared there. I'm grateful for all of you spending the time to present for us. I think there's a few questions in the chat, so I'd like to open up the floor for everybody in the room, or the virtual room, for any questions or any general discussion. So it's not just a question as such, but if you have a comment or you want to share some insight, then please do. There is the raise hand emoji at the top bar. So if you look at the reactions, you can raise your hand, or like I say, use the chat function. And if there's any ones that are prioritised, if people like them, we can go on those. So we have a short amount of time, about 20 minutes or so, to have a good chat. I will stop presenting so we can all see one another. So if you want to put your cameras on, please do so. Okay. Let me make sure I can see my chat as well. So I'm just going to go to the first one that came in the chat. There was a question. raised by Marlene. I think if Marlene is still here, and that was during Rachel's presentation. I think there was a question saying, was there an explanation as to why boys score 10% higher than girls for ideal cardiovascular health? I don't know, Rachel, whether you are able to answer that for Marlene, please.
Yeah, sure. Thank you very much for the question, Marlene. So I guess it's hard to say exactly, but typically in the literature, boys are more active than girls. It's been shown in a number of studies. So I think that this was probably a driving factor. It's certainly what we saw in our study as well. And then because they're more physically active, they're more likely to have lower BMI and lower cholesterol levels as well, which is what we also observed. So combined, that contributed to a higher cardiovascular health compared to girls who had poorer cardiovascular health.
Thanks, Rachel. We had a few more in the question. Well, there's some general comments from Marianne. I'm not sure that's necessarily a question. Marianne, do you have anything to add to your comment? If not, we shall move on. I think, David, you've actually responded to that. And then there's Marlene, you made a comment to David as well. Do you want to expand on that at all? No? No. Okay, well, I think we have a hand up. I think it's Phil. Phil, do you want to unmute yourself and ask your question or raise your point? Thank you.
Phil, I've just given you permission to speak, sorry.
I was just going to say, is he prevented? Do we need to disable it, Claire? Not sure what's happening.
That should work now. Sorry, everybody.
Thanks, Claire.
I'm muting, yeah. Can you hear me?
Sorry.
Can you hear me?
Yes, we can.
Yeah,
Thank
great.
you, Phil.
Sorry, yeah. I think there's a few things that perhaps we could look at that might sort of improve the results that we've got, and to maybe look at a preventative sort of plan or framework or something. Firstly, I think that there's obviously from what's being presented, there's a need for a screening program of some kind. You know, I would also include in that, you know, whether there are any differences with population groups like ethnicity and things, because particularly when you're looking at young children, you know, there are things like sickle cell disease, and all of these are contributing factors to, you know, hypertension and stuff. And also for the measuring of those population groups, what were the demographics that we used? Because we seem to miss a lot of people that move around these days. Things like immigration, things like Romani, Gypsy communities, travellers, those types of communities. So we exclude those, and those are all kind of high risk groups that get missed consistently. I think that, you know, it's all a lot of it is about influencing local policy and national policy. And for example, with David's example around Doncaster and Bassetlaw, I'd be jumping up and down and banging on doors and screaming and shouting at the CCGs or the integrated care services about, you know, we need to stop this. We need to get some people out there measuring people, you know, whether health checks are done in the community. You know, I just see that there's lots of things that could be integrated into different things. Air quality, I know, has been poor in Doncaster areas because of the power stations and stuff in the past and things. And are people living with multiple conditions as well? You know, this is another consideration that I think it needs to be brought in. Are we doing proper screening of cholesterol? You know, we're getting cholesterol levels, but what's actually in that cholesterol? You know, what's the good and what's the bad in there, you know? And are some of them genetic, or are some of them things that we should be, you know, getting researchers to look at, like lipoprotein(a) and stuff like that, and whether mRNA, which is used for increasing proteins in things like the COVID vaccines, whether that could be reversed, maybe get rid of that horrible sticky lipoprotein(a), which is something that carries all that cholesterol around our bodies and liver and kidneys and stuff. So yeah, I just think there's lots of stuff there that needs looking at, I think. Sorry.
No, thank you, Phil. That's some useful points there. I don't know whether one of the LongITools researchers or Jerome has any kind of comments based on some of that, particularly the kind of demographics. I think if I understood rightly, you were saying that the people that are probably in these cohorts are the ones that stay put and are actively engaged, whereas the other risk groups are ones that you probably aren't going to capture because they're moving around or don't engage with such kind of cohort activities. But I don't know whether you've got any comments, Sylvain, Anna or Rachel.
I can add a comment. So I think I completely agree, Phil, with your comments. I think in the Eden cohort, for example, the cohort of mothers who were included are quite healthy. They're predominantly Caucasian, and compared to some other cohorts that have also more American cohorts, we actually, because we didn't see many differences or an impact of maternal factors on the child's cardiovascular health within the Eden cohort, but other cohorts that are less healthy have seen impacts. And so I think the findings were impacted by having more of a healthy cohort. So I completely agree that we do need to be including those people who are more at risk in these projects. But it's hard to recruit those people because, as David was saying, they're not necessarily the worried ones who put their hands up to be involved in research projects.
Thank you, Rachel. Sylvain, you have your hand up.
Yes, absolutely. Well, it was, of course, it was, well, it's in line with what Rachel was saying, and that's why I think we are trying in many of those projects, like Jeroen was promoting, that we compare very, very large population to scratch up a little bit the surface and more specific population to see what's happening in different age group, etc. But this is absolutely true, and we all are missing this granularity for the group at risk. That's why I think we are making those events to realize that there's a need to focus and also co-create and engage some population that can work together, because I don't believe that they are not interested. It's just that we sometimes haven't found the way to engage with them. And another thing is there are little things at work, as Rachel was showing, that we have evidence that something works. So it is very important also that we can show those data, that it's, of course, it's, as David was saying, so you are not here to treat the society, you are here to treat the patient, but we have to find also solutions. But if we found ways to show that there's evidence that early life can promote health or different things, I believe this would, I'm optimistic today.
Thanks, Sylvain. Jeroen, you have your hand up.
Yes, just to add also to Sylvain what he already said, that the opportunity of using administrative cohorts are likely using electronic health records of people who are within, for example, a public health or the health system, for example, NHS or other systems in Europe, and then you would actually capture more broad and everyone within society. You won't capture those people who don't have access to health, which are as a large also, like, for example, immigration problems that we cannot capture, but we still can capture, for example, more low social groups that you cannot capture with adult cohorts. And I think this is also a great opportunity to focus on environmental justice, to see that more deprived communities are also exposed to higher levels of air pollution and less access to green spaces, but that varies within Europe. So and that can also affect great health environmental disparities. So that's things we can address in the exposome projects.
Thanks, Jerome. Does anybody else have any extra points to say? I know there's been some comments in the chat, been sharing some information. Do we have any more points or questions for any of the speakers? We do have a fellow GP from Doncaster. I'm not sure whether he's still here. Nabil, I think you contributed or kind of liaised with David on his presentation. Did you have anything you wanted to add? I know he had to go a bit early, so he might have left.
I'm just about to end my bit on the call. I don't think so. I know there was the earlier point made about what the CCGs have done on this, and I think it's a fair point and a fair challenge. This is sort of everyone's problem for us, and I know that some of the new systems and how closely we work with local authority and on commissioning and some of the services aimed at the groups of practices, the primary care networks are around CVD prevention and tackling health inequalities. So I'm hoping progress will be made in this space, but it's obviously a really difficult area, and there's a small amount that we have direct influence over, but there's a lot that we have to work with colleagues on.
Thank you, Nabil. Okay, anybody?
Joanne.
Yes, sorry, Rachel, go ahead.
To interrupt, can I ask a question, please?
Yes, of course.
I would like to ask all my European colleagues here. What is your experience, to all of you, the panel, engaging with policy and influencing policy? Because here in Australia, I'm sure it's very similar over in Europe. I met with a local politician a little while ago and was talking about the research in prevention of cardiovascular disease and so on. And he was saying to me that, you know, it's quite a challenge for us because they have sugar lobbyists coming into them every week, lobbying them about, you know, no taxes on sugar sweetened beverages and so on. So they're in there in his office every week, and I'm here once every, you know, whatever, in a blue moon. So I feel like we're almost fighting a losing battle in a way, trying to work against these big organisations and, you know, industries. So does anyone have any comments or thoughts on that?
Birgit to put a hand up.
Yeah, definitely. I mean, that's our main bread and butter, to talk to politicians and to convince, let's say, at European level from the Secretariat and but also at national level through our members to reach national policymakers. So we really try hard to work on these. Of course, politics is it follows interests, and as you say, there are industries very strong and very well resourced to take up the battle and work in the favor of their interests. For example, the tobacco industry is a very, very strong lobby. We've seen whenever there's a legislation on tobacco control, we are David and Goliath fighting against each other to take a biblical picture here. But I think at the moment, as I mentioned in the beginning, I think we are seeing a shift at the moment. Somehow the cardiovascular health is becoming more into the focus of what it means and what it would bring to society overall if we intervene better earlier, because we have an issue as with a huge economic but also epidemiological burden coming up in the next years. As you say, the young children getting obese, what will they become in the future? And even young people, as David said, 20-year-old prisoners with the multimorbidities. I mean, this is terrible. So I think it is really now time for policymakers to wake up, and where we saw a bit on a focus on cancer for the past years, at least at European level. And sometimes also my national members were complaining it's all about cancer. I think at the moment we are catching up, and with NCDs, non-communicable diseases overall, but very much with cardiovascular health as well. So this is a good sign, inspiring. But we have to keep on talking to policymakers and not being the last ones in the blue moon, but rather trying to keep up a constant dialogue. And this is really an important job. And then I think also reaching the wider population to increase the level of health literacy, so that we maybe have more worried people, not in a negative way, but in a positive worried way, in a caring way, to take care of their own health, but also of their environment, their children, and their relatives and friends and family. So I think that is a bit of a task which we all have to do, a bit to talk about, to make health a topic everybody should be interested in, for its own sake, but also for the sake of everybody. Yeah, thank you. Over.
Thank you, Birgit. I think we have another couple of hands up. I think it was Marlene first and then Marianne. Marlene first.
Yeah, thank you. I work for the European Heart Network, and just to follow up on this, we have already developed quite a lot of policy measures that are effective in realizing this further reduction of cardiovascular diseases in particular, but also non-communicable diseases in general. One of the most effective, but also the most difficult measures that we would like to see implemented is, for instance, a reduction on marketing of unhealthy foods to children. We are pushing very hard for this at European level to have bans on marketing of unhealthy foods. As you indicated correctly, Rachel, the lobby of the food industry is extremely vocal on this one, but we have as a motto that the louder the industry shouts, the more we think it hurts, and the more we should continue pushing for those measures that we want to achieve there. To go even further, we are discussing with a group of other health NGOs in Europe to have something not similar as the Framework Convention on Tobacco Control, but if you talk healthy diets, why should the food industry participate in the discussion? Their objective is not to have to sell healthy food. Their objective is to sell food and to make profit. And it is not for them to set the way healthy diets should be interpreted. At European level, we have long discussions now on whether a diet should be healthy or should be balanced. And we were very surprised to see that is even still a debate that we should be having when we talk of sustainable foods and sustainable societies. We cannot even, the food industry was present in these discussions, and we could not even have an agreement that the diets at least should be healthy. All they wanted to achieve is that the diets should be balanced, which means that every food product should be considered in a diet. And this is definitely not the vision that as health NGOs that we want to go for. There are a lot of other examples. We have, together with the European Society of Cardiology, we had a lot of, developed a cardiovascular health plan, which focuses a lot on prevention measures, on policy measures that politicians should take, not just on primary prevention, but also on secondary and prevention, also in the field of research, also in the field of patient care. Really very concrete policy measures are set in there. I can send you the link, or I can send you the plan for those measures that we would definitely advocate for. And it goes from, as I said, reduce marketing, set nutrient profiles is another one where we would really like policymakers to take very, very strict action on how to set on what nutrient profiles would be set. Front of pack nutrition labeling is another one that should guide people towards healthier diets, not just towards more sustainable diets, but really towards healthier diets as well. All these measures, I will put the link to the plan in the chat box if you like, and then we can take it further from there. Thank you.
Thank you, Marlene. That would be really great. Thank you.
Thanks. Yeah.
Thank you, Marlene. Marianne?
Yes, well, I'm the vice chair of the Dutch Health Council, and there we have committees of independent scientific experts who make the advice on all kind of topics related to public health and healthcare for the Netherlands. So these committees of experts are all screened for any conflicts of interest. And if we want to hear the opinion of those with potential conflicts of interest, we make hearing sessions, but they don't actually contribute to the advice. So we do have a so-called independent scientific based advice on all these different topics like dietary intakes, but also air pollution and any kind of exposure, but also clinical care issues. So that's quite powerful, I can say, because a lot of that is actually implemented in food and health policy. So the problem in our country is mainly that, like, health issues are with the Ministry of Health, and environmental issues are to some extent with the Infrastructure and Water Management Department, and agriculture is with the other departments. So it's more that interdepartmental problem that they don't take full responsibility then, because there's collaboration is needed with other departments, also with the Economic Affairs Department, and that's the actual problem. So, but at least we do have some independent scientific opinion, and I can share the website with you in the chat. So, and that's quite an intense process to come to such an opinion, but it's really helping to get things clear. Where does the advice come from, and does the minister follow up on that, or is he lobbied by food industry or whatever?
Thank you, Marianne. That's great. Is there any more comments, Marlene? I think you've still got your hand up, or is it okay? Well, we're nearly about time as well, so unless anyone's got anything they want to just raise before I start to wrap things up. No? Okay. Bear with me. Okay, so just a few concluding remarks. First of all, thank you very much for everybody's time and input today, particularly the speakers who've done the slides and prepared in advance as well for us. We would really like to let people to keep in touch with what we're doing going forward. So there are a few ways you can do that. We have a LongITools innovation platform, which is where we're going to feature our key outputs from the project. Jerome mentioned his toolbox, so there's a link there, or the pathway there for the Expanse toolbox. And all of the tools that are generated, or all of the outputs, or the key things that might be used and relevant to the discussions today, will be featured on the eHEN toolbox, which is on the eHEN website. So that's where policymakers and interested parties can go and get all the outputs from all of the projects. Obviously, they're not all on there yet, because we've still got another couple of years to go. There's also, if you want, we're going to hold another one of these policy forums on March the 29th of next year. The subject on that's still to be decided. So if anyone has any ideas about what you would like to discuss, whether there's you would like to have a similar kind of forum going forward, so we can kind of get some more updates and see if we can progress things further, then please let us know. You can follow us on Twitter and LinkedIn, and as last bit of admin, could you please complete our feedback form if you've got time? It's literally 4 questions. You just need to tick a few boxes. It just helps us make sure that we're doing things right and improve them if we can. So once again, a massive thank you to everybody who's taken part, and I look forward to the next forum. Hopefully you'll be able to attend that and enjoy the rest of your day. Thank you all. Bye.
Thank you.